Pediatric Surgery. Dermoid cysts. Definition: congenital inclusion cyst of the skin and skin appendages, lined by stratified squamous epithelium. Desquamation occurs, leading to sebaceous cheesy material inside the cyst, site on the scalp and eyebrows, most commonly in the midline of the nose, neck, and upper chest. Clinical picture: painless swellings, completely mobile or fixed to the skin, and deeper structures. Dermoid cysts of the eyebrows and scalp. Depression of the underlying bone, leading to smooth punched-out defect on radiographs of the outer table of the skull. They don't extend intracranially. Treatment: they should be excised intact. Incomplete removal leads to recurrence. Those arising near the eyebrows should be excised through incision adjacent to the hairline. The eyebrows shouldn't be shaved, nor should the incision go through an eyebrow follicles, if so, permanent area without hair. There are reports of removing facial dermoids using an endoscope by incision in the scalp to avoid facial scar. Cysts of the face and scalp that are located in midline can extend intracranially, so it's essential to obtain MRI or CT scan pre-operatively. Dermoid cyst of the midline neck may be confused with thyroglossal duct cyst. Dermoids don't move with swallowing or tongue protrusion, as they are not deep to the strap muscles, unlike thyroglossal cyst. Branchial anomalies. During the first months of fetal life, the primitive neck develops 4 external clefts and 4 pharyngeal pouches, separated by a membrane. Between the clefts and the pouches are branchial arches. The dorsal portion of the first cleft becomes the external auditory canal. The other clefts are obliterated. The pharyngeal pouches persist as adult organs. First pouch, auditory tube, middle ear cavity, and mastoid ear cells. Second pouch, incompletely regresses and becomes the palatine tonsil and supratonsillar fossa. Third pouch, the inferior parathyroid gland and the thymus. Fourth pouch forms the superior parathyroid glands. Fistulae, communicating between the anterior border of the sternocleidomastoid muscle and tonsillar fossa, are of the second branchial origin. Second branchial cleft abnormalities occur 6 times more than the first cleft anomalies. Branchial anomalies are remnants of fetal branchial apparatus, a tract of branchial origin, complete fistula formation. One end may be obliterated, and external or internal sinus formation. Both ends may be obliterated, leading to aggregate of cells and formation of a cyst. Branchial cyst and fistula. Etiology: normal development and abnormal development. Normal development: during embryological development, second branchial arch grows rapidly, covering the third and the fourth arches. Then it fuses with the neck. The space between the second arch and rest of the arches turns into a cervical sinus, which disappears. Abnormal development: a branchial fistula develops if second arch doesn't completely fuse with the neck. If the cervical sinus persists, it leads to branchial cyst formation. Pathology: a branchial cyst lining squamous epithelium, content clear fluid rich in cholesterol crystals, microscopically identified in aspirated cyst fluid. The cyst wall is surrounded by lymphatic tissues, which get infected. A branchial fistula. Etiology: usually congenital but occasionally secondary to ruptured, infected branchial cyst. The tract lined by squamous or ciliated epithelium, extension up to the side wall of the nasopharynx, leading to something called fossa of Rosenmuller. Course: passes between the bifurcation of the common carotid artery, deep to the posterior belly of digastric muscle, and superficial to the hypoglossal nerve. Clinical picture: branchial cyst, usually appears at late childhood, presents as swelling protruding from beneath the interior border of the upper third of the sternomastoid muscle, has smooth surface, mobile and fluctuant, commonly mistaken for a cold abscess differentiated by finding cholesterol crystals in the aspirate. Branchial fistula presents at birth as pinpoint opening at the anterior border of the lower third of the sternomastoid muscle. The opening discharges mucoid material, but when gets infected, it becomes purulent, may occasionally be confused with a tuberculous sinus. Differential diagnosis: granulomatous lymphadenitis, suppurative lymphadenitis, hemangiomas and lymphangiomas, carotid body tumors, and lymphomas. Granulomatous lymphadenitis, due to mycobacterial infections, produce cystic lymph nodes and draining sinuses. They are characteristic by the chronic inflammatory reaction which precedes the purulent discharge. Suppurative lymphadenitis, due to Staphylococcus aureus resembling infected branchial remnant. Lymphadenitis is curative, and completely heals while the branchial remnant persists after the infection resolves. Hemangiomas and lymphangiomas, they are soft, spongy tumor masses. Branchial cysts have firmer consistency. Lymphangiomas may transilluminate while the branchial cysts, they don't. Carotid body tumors, they are quite firm, located at the carotid bifurcation, occur in older patients. Lymphomas, they produce firm masses in the area where the branchial remnants occur, but multiple matted nodes rather than a solitary cystic tumor. Firm cord-like tract may be palpable along its course. Nearly all branchial abnormalities should be excised early in life since repeated infection is common, leading to difficult resection. Treatment: branchial cyst by excision through transverse neck incision, and for the branchial fistula, the whole tract should be excised through multiple transverse neck incisions, small one around the fistula opening, the other at higher level below the jaw. A ureteric catheter is introduced into the tract to facilitate its identification during surgery. Infected sinuses and cysts require initial incision and drainage. 6 weeks later, when the acute inflammation subsides, staged excision of the tracts. Ensure complete excision of the cyst wall or fistula tract, including skin punctum, since incomplete removal leads to recurrence and infection. Take care to not injure any of the following important structures, such as internal jugular vein, carotid artery, nerves such as the facial hypoglossal and the glossopharyngeal nerves. Lymphangioma or cystic hygroma. Definition: benign multilobular multinodular cystic masses lined by endothelial cells. Etiology: normal development. The lymphatic system develops by the coalescence of multiple small lymph vesicles, leading to large accumulation present lateral to the jugular vein, and they are called jugular lymph sacs. Abnormal development: if some vesicles of the jugular lymph sac fail to join the lymphatic system, they become sequestrated and form cystic hygroma. Pathology: site most commonly in the posterior triangle of the neck 75%, in the axilla 20%, the remainder in the mediastinum, retroperitoneum, pelvis and groin. Gross picture: the swelling consists of multiple cysts with larger ones near the surface, while the smaller ones are deep and infiltrating tissue planes. Microscopic picture: each cyst is lined by endothelial cells and contains clear lymph. Clinical picture: type of the patient: 50 to 65% appears at birth and 90% are evident by the second year of life. Symptoms: the majority are asymptomatic, painless swelling, large lesions invading the floor of the mouth, leading to symptoms referable to the pharyngeal or upper airway obstruction. Signs: the swelling appears bluish, translucent to light, soft, partially compressible, increases in size with coughing and crying. The skin is never involved, although the lesion may be densely adherent to the undersurface of the dermis. Treatment: there are two modes of treatment. The choice depends on imaging studies such as CT and MRI. Sclerotherapy and excision. Sclerotherapy indications: this is the most effective for unilocular or macrocystic lesions. Method: intralegional injection of sclerosing agent such as bleomycin, doxycycline, OK-432, a lyophilized mixture of Streptococcus pyogenes and penicillin G potassium. Excision method: bipolar cautery to ensure a homeostatic dissection and decreasing the incidence of lymph leak and nerve injury. Recurrence rate following surgery is 50%. Periauricular lesions: anomalous development of the auricle. Preauricular sinuses, cysts, and cartilaginous are unrelated to the branchial anomalies. The sinuses are often short and end blindly. They can be cosmetically unappealing and often become infected. Superficial skin tags and cartilaginous rests are easily excised without the risk to other structures. Periauricular sinus tracts may be very deceptive in their extent, and extensive dissection has risks to damage branches of the facial nerve. Thyroglossal cyst. Etiology: normal development. During the 4th week of gestation, the thyroid gland develops from an invagination in the floor of the primitive pharynx located between the first pair of pharyngeal pouches. Abnormality: if the thyroid doesn't descend normally, mass at the base of the tongue or anywhere in the midline of the neck along the path of descent. If the thyroglossal duct persists, the epithelial tract forms a cyst, which usually communicates with the foramen cecum of the tongue. The thyroglossal duct descends through the second branchial arch, which becomes the hyoid bone, prior to its fusion in the midline. Therefore, the persistent tract often extends through the hyoid bone. The thyroglossal duct can assume a variable relationship to the hyoid bone, behind, in front, or through the body of the bone. Carcinoma develops more frequently in ectopic thyroid tissue than in normal thyroid glands. Pathology: midline tubulodermoid cyst arising in thyroglossal duct remnant site at any level from the foramen cecum of the tongue to the suprasternal notch, commonly in the midline just below the hyoid bone at the level of the thyroid cartilage, displaced usually to the left. Clinical picture: type of the patient at any age but most commonly during childhood. Symptoms: painless cystic swelling in midline of the neck. Signs: cystic midline mass moving up and down on swallowing since they are deep to the cervical strap muscles and on protrusion of the tongue due to its relation to the hyoid bone. There may be palpable tract extending from the hyoid bone upwards towards the tongue. The fluid in the cyst is usually under pressure, giving the impression of being a solid tumor. Differential diagnosis: lymph nodes, dermoid cysts, they don't move with swallowing, enlarged prelaryngeal lymph nodes containing tumor metastasis, and lingual thyroid. Complications: there's malignant potential of the dysgenetic thyroid tissue located in the thyroglossal duct cyst, excision of an ectopic thyroid, removal of all thyroid tissue leading to hypothyroidism, thyroglossal fistula, the tract is lined by columnar epithelium. Etiology: the wall of the cyst is rich in lymphatics which communicate with the cervical lymph nodes, leading to infection, spontaneous rupture or incision and drainage. Fistula: inadequate removal of the cyst. Clinical picture: the opening of the fistula is near the midline on the left side with crescentic fold, discharges mucus and presents with recurrent inflammation. Treatment: complete excision is indicated because of the risk of infection and the possibility of development of papillary carcinoma later in life. Acute infection in the thyroglossal tract should be treated with local heat and antibiotics. After inflammation subsides within 6 weeks, incision and drainage by cyst trunk procedure, removal of the thyroglossal cyst, its epithelial tract. The mid portion of the hyoid bone should be removed en bloc with the thyroglossal tract to the base of the tongue. When the hyoid is not removed, it leads to recurrence. Lingual thyroid. Etiology: failure of descent of the thyroid. Clinical picture: tongue swelling with obstructive manifestations such as dysphagia, dysphonia, dyspnea, pain or hemorrhage. Differential diagnosis: the lingual thyroid may be confused with a hypertrophied lingual tonsil, ranula, fibroma, angioma, sarcoma or carcinoma of the tongue, thyroglossal cyst. Differentiated from aberrantly located thyroid glands by needle aspiration or radioiodine CT scan. Investigation: thyroid scans, absence of thyroid tissue in normal site of the neck. Treatment: full replacement with L-thyroxine, reduction in the size, surgical extirpation, and finally radioactive iodine ablation. Sternomastoid tumor and congenital torticollis. Normal development: the sternomastoid muscle develops through the union of 3 somites, each with its own blood supply. Abnormal development: interruption of the blood supply to the central somite, whether before or at birth, leading to muscle infarction, becomes swollen, called sternomastoid tumor. Fibrous tissue will replace the infarcted part, leading to contraction, causing congenital torticollis. Clinical picture: presents at birth or 2nd to 6 weeks of life. More common: presents with hard non-tender fibrotic mass within the sternomastoid muscle. The muscle is shortened. The mastoid process on the involved side is pulled down towards the clavicle and manubrium. The head is abducted to the ipsilateral side, rotated to the contralateral side towards the opposite shoulder. The shoulder is on the affected side is raised, and there may be cervical and thoracic scoliosis, passive rotation of the head to the involved side, and resistance and limited movement to the varying degrees, and muscle appear as protuberant band. Differential diagnosis: worry neck, WRY neck, worry neck. Its fibrocytes causing spasm of sternomastoid muscle, temporary, lasting for a day or 2. Response to anti-inflammatory drugs. Treatment: with active range of motion exercises. The child's shoulders are held flat to a table and the head is tilted and rotated in a full range of motion. Performed at least 4 times a day for 2 to 3 months. Surgery: rarely necessary. Indication: if the muscle continues to become progressively shortened with facial and occipital skull deformity. Method: Both heads of the sternocleidomastoid muscle should be divided through small transverse incision just above the clavicle. This procedure doesn't reverse the bony changes which have already developed, but it prevents progression of the process. Recurrence is rare. Congenital diaphragmatic hernia, incidence 1 to 2,000 live birth, highly lethal or morbid disease, embryology, normal development, fusion of the transverse septum and pleuroperitoneal folds during the 8th week of embryonic development, intestine returns to abdomen for rotation and fixation at the 10th week, abnormality if diaphragmatic formation is incomplete, embryologic fusion defect, the pleuroperitoneal hiatus, foramen of Pogdalic persists, herniation of intra-abdominal contents into the chest, pulmonary hypoplasia and hypertension, and cardiac dysfunction occur. Intestinal non-rotation is common as the bowel herniate into the thorax rather than the undergoing its normal sequence of rotation and fixation. Left side of diaphragm is affected 4 to 5 times as frequently as the right, with a rate of associated anomalies of 20%. Chromosomal abnormalities and neural tube defects plus congenital heart diseases. The larger the hernia and the earlier it occurs, the more severe pulmonary hypoplasia occurs. Types: foramen of Morgagni, only 2%, occurs at the junction of the septum transversum and the anterior thoracic wall, central diaphragmatic defect. It may be parasternal, retrosternal, or bilateral. Pogdalic hernias, commonest. Defect is posterior. Children are asymptomatic and defect is discovered accidentally later in life on a chest radiograph taken for another unrelated reasons. The lateral chest radiograph demonstrating air-filled mass extending into the anterior mediastinum is pathognomonic. Clinical picture: symptoms: large diaphragmatic defects, symptomatic in the delivery room with tachypnea, grunting, respiration, retraction, and cyanosis. Smaller defects, not symptomatic until several days or months. Signs: abdomen, scaphoid, as most of the abdominal viscera are in the hemothorax. The chest, on the side of hernia, dull to percussion, but bowel sounds are not usually appreciated. When the hernia is on the left, heart sounds may be heard best on the right side of the chest. Investigations: chest x-ray may demonstrate the following: minimal amount of gas within the abdomen, radiopaque hemothorax, if the bowel doesn't contain a significant amount of gas, or if the left lobe of the liver occupies the majority of the hemothorax. Loss of normal ipsilateral diaphragmatic contour, bowel in the thorax, contralateral mediastinal shaft, coid nasogastric tube in the hemothorax. Treatment: surgical after preoperative preparation. Preoperative preparation: nasogastric tube to decompress the stomach and prevent distension of the herniated bowel, which would further compress the lungs. Respiratory support: mechanical ventilator. Never use oxygen mask for hypoxemia, hypercapnia, and acidosis before and after repair. Surgery: subcostal abdominal incision. Some prefer thoracic approaches, especially for right-sided defects, whether open or thoracoscopically. The herniated bowel reduced from the pleural space. Close the defect by non-absorbable sutures. Synthetic material required to close large defects. Placement of a chest tube in the pleural space is optional. If used, it's connected to a water seal and not to a vacuum. Post-operative mechanical ventilation. Repair of the diaphragmatic defect is not a surgical emergency and should be done once the infant is stable and has minimal or no pulmonary hypertension. In the asymptomatic patient, no pulmonary hypoplasia or hypertension, repair is needed due to the risk of bowel obstruction. The viscera are reduced and any associated hernia sac is excised. The defect is closed by suturing the posterior rim of the diaphragm to the posterior rectus sheath. Since there is no anterior diaphragm, rarely a prosthetic patch closure is required. Eventration of the diaphragm. Etiology: whether congenital or acquired. Congenital, usually idiopathic, but can be associated with congenital myopathies or intrauterine infections. There is variable thinning or absence of diaphragmatic muscle. Acquired, as a result of phrenic nerve injury during forceps delivery or surgery. Definition of the eventration of the diaphragm: it's an abnormally elevated or attenuated portion of the diaphragm. Clinical picture: the elevated hemidiaphragm leads to abnormalities in the chest wall mechanics, leading to impaired pulmonary function, leading to respiratory distress and pneumonia. Investigations: chest radiograph, fluoroscopy or ultrasound demonstrating paradoxical movement of the diaphragm during spontaneous respiration. Treatment: surgical. Indication: there are associated respiratory symptoms. Method: plicating the diaphragm using interrupted non-absorbable sutures. Esophageal anomalies. Embryology. The trachea and esophagus are derived from primitive foregut. Initially, they appear as common ventral diverticulum at about the 19th day of gestation. Several days later, elongation and separation of the diverticulum into airway and esophagus in a coded to cephalic direction. Errors in this lead to esophageal atresia, tracheoesophageal fistula, and their variants. Classification. With esophageal atresia, there's blind proximal pouch and fistula between the distal end of the esophagus and the distal 1/3 of the trachea, which is type C, 85%. There's blind proximal esophageal pouch, no tracheoesophageal fistula, and blind short distal esophagus, and this is called type A, 10%, is called pure or long gap atresia. There are fistulae between both proximal and distal esophageal segments and the trachea. This is type D, 2% of the cases, and there's fistula between the proximal esophagus and trachea, and a blind distal esophagus without fistula, type B, 1% of the cases. Without esophageal atresia, there's an H-type tracheoesophageal fistula, which is usually present in the lower cervical region, type E, 4 to 5% of the cases. There's esophageal stenosis consisting of a membranous occlusion, often containing cartilage between the mid and distal third of the esophagus, which is rare. There is laryngeotracheoesophageal cleft of varying length, consisting of a linear communication between these structures, which is very rare. Clinical picture. Shortly after birth, pseudo-excessive salivation, repeated episodes of coughing, choking, and cyanosis, attempts at feeding leading to choking, gagging, and regurgitation, pneumonia, infants with tracheoesophageal fistula in addition to esophageal atresia, reflux of gastric secretions into the tracheobronchial tree, which leads to pneumonia, and this is the cause of death. Investigations. Catheter test. A size 10F catheter passed into the esophagus through the nose or mouth. If esophageal atresia is present, the tube will coil in the upper esophageal pouch and they don't go down the expected distance. Chest X-ray. If the air present in the stomach and bowel, tracheoesophageal fistula connects to the lower esophageal segment. Absence of air below diaphragm, no distal fistula. Pulmonary infiltrates are usually noted first in the upper right loop. Bronchoscopy determines the presence and position of the fistula. The best investigation is the chest X-ray. Associated anomaly incidence 50%, which are cardiac, PDA, septal defects, GIT, imperforate anus, duodenal atresia, genitourinary and skeletal, and we have something called VACTERL, VACTERL, association in 25% of the cases. V vertebral, A in rectal, C cardiac, T tracheoesophageal, and R for renal, L for limb. Isolated esophageal atresia has been associated with various genetic abnormalities, including trisomy 18 and trisomy 21. Associated congenital anomalies should be treated. Treatment. Preoperative preparation and the operation itself. Preoperative, a suction catheter should be placed in the upper esophageal pouch and the head of the bed is elevated. An echocardiogram is to determine the position of the aortic arch, and a right-sided arch present in 5%, making the standard right thoracotomy or thoracoscopic repair difficult. Treatment of aspiration pneumonia if possible. Operation. One stage or staged operation. One stage operation. Right posterolateral thoracotomy with an extrapleural dissection. Divide and ligate the fistula. Repair the atresia. Staged operation indications. We have extremely premature babies, severe aspiration pneumonitis, and those with severe anomalies, long gaps between the esophageal pouches. Methods, whether by cervical esophagostomy, division of the fistula and insertion of gastrostomy tube after several months, leading to staged reconstruction by esophageal replacement with colon or stomach interposition. A gastrostomy tube alone with intermittent bouginage and stretching of the upper esophageal pouch, followed by immediate interposition grafting and delayed primary esophageal anastomosis. Hypertrophic pyloric stenosis or CHPS incidence, male to female ratio incidence is 4:1. Most common surgical disorder producing emesis in infancy. Disorder is more common in firstborn infants. Symptoms show seasonal variation leading to peak in spring and fall. Etiology is exactly unknown. Pathogenesis, hypertrophy of the circular and longitudinal muscularis of the pylorus, and distal stomach antrum, progressive narrowing of the pyloric canal, The affected infant is full term when born, feeds and grows well until 2 to 4 weeks after birth. Clinical picture: symptoms appear 2 to 4 weeks after birth. Vomiting, occasional regurgitation of some of the feedings. Several days later, they become more frequent and forceful. No bile and contains the previous feeding. Shortly after vomiting, the infant acts starved and will feed again. Constipation, the stools become infrequent and firm in consistency. Failure to thrive, progressive feeding intolerance, leading to weight loss. Signs: general dehydration, sunken fontanelles, dry mucous membranes, and poor skin turgor. Local inspection: gastric peristaltic wave moving from the left costal margin to the area of the pylorus. Palpation: pyloric tumor or olive when the infant is relaxed in over 90%. Imaging study is indicated when the pyloric tumor cannot be palpated. Complications: dehydration, starvation, gastritis and reflux esophagitis, aspiration pneumonia, and hypochloremic alkalosis due to repeated vomiting with inadequate intake of the formula, leading to paradoxical aciduria. Investigations: abdominal ultrasound, the most sensitive and specific test. Identify hypertrophied pyloric stenosis when the muscle thickness is more than 4 mm, the length of pylorus is more than 16 mm, a contrast upper GI serous. Indications: absence of experienced ultrasonographer. The patient's symptoms may not due to pyloric stenosis, such as premature or 1-week-old baby. Positive diagnostic signs are string sign, narrow pyloric channel, pyloric peak, bulge in the distal antrum with streak of barium pointing towards the pyloric canal, the shoulder sign, the pyloric mass bulging into the antrum, complete obstruction of the pylorus. Differential diagnosis: repeated non-bilious vomiting in early infancy may be due to overfeeding, pylorospasm, gastroesophageal reflux, duodenal stenosis, intracranial lesions, antral web, pyloric duplication, and adrenal insufficiency. Treatment: operative by pyloromyotomy, preoperative preparation, correcting dehydration, correcting hypochloremic alkalosis, giving normal serum chloride, urine output more than 1 cc per kilogram per hour. Operation: pylorus is incised along its entire length and spread widely, exposing but not reaching the underlying mucosa. Approaches to pyloromyotomy: 3. Right upper quadrant transverse skin incision, threaded Ramstedt pyloromyotomy, circumbilical skin incision, and laparoscopic approach. Intestinal obstruction in the newborn: it can be diagnosed prenatally by ultrasound. Polyhydramnios, since fetuses continually swallow amniotic fluid into their GIT and excrete it in their urine. After birth, vomiting is the principal symptom. Level: if bile stained, obstruction distal to the ampulla of Vater, and presence and degree of distension by physical examination. Duodenal obstruction, no significant distension, while colonic obstruction massive, as in Hirschsprung's disease. Careful perineal examination determines the anus is present, patent, and in normal location. Duodenal atresia is diagnosed early in gestation rather than distal GIT atresia due to mesenteric vascular abnormality late in gestation. Congenital duodenal obstruction incidence: duodenal atresia is twice as common as in the jejunum or ileum. Causes: stenosis, annular pancreas, atresia, failure of recanalization, mucosal web, complete or variably perforate pre-duodenal portal vein, peritoneal bands, Ladd's bands from malrotation. Clinical picture: bilious emesis in 75% of the cases occur shortly after birth and during attempt feedings. Upper abdominal distension, rare. Investigations: plain abdominal X-ray showing air distended stomach and duodenum, double bubble sign. Gas in the small and large intestine indicates incomplete obstruction. Barium meal or gastrography, and identify the presence or absence of malrotation in those cases with incomplete obstruction. Obstruction from intestinal malrotation is a surgical emergency. Gastrojejunostomy shouldn't be done because a blind duodenal pouch may cause repeated vomiting. Surgery: right upper transverse abdominal incision or by laparoscopy. Couture maneuver should be performed with complete mobilization of third and fourth portions of the duodenum. Obstruction from Ladd's bands, simple bands division, and correction of malrotation. Duodenal atresia and annular pancreas. Duodenostomy. Mucosal web exercised to avoid injury of the adjacent ampulla. In all cases, irrigate the distal bowel, assess for associated intrinsic obstruction and atresia, which is present in 1 to 3%. Atresia and stenosis of the jejunum, ileum, and colon, etiology and pathogenesis in utero hernia, volvulus or intussusception, mesenteric vascular accident leading to aseptic necrosis and resorption of the necrotic bowel, types type 1, 2, 3A, 3B, and type 4. Type 1, short area of necrosis, only stenosis or membranous web occluding the lumen. Type 2, extensive infarct, fibrous cord between the two bowel loops. Type 3A, proximal and distal bowel completely separated with V-shaped defect in the mesentery. Type 3B, apple peel or Christmas tree atresia, which there is blind ending proximal jejunum, absence of long length of mid-small bowel, and terminal ileum coiled around its weak blood supply from ileocolic vessel. Type 4, in 10% of cases, multiple atresias occur. Clinical picture: vomiting of bile, abdominal distension, failure to pass meconium. Investigations: barium enema may be indicated to detect the level of obstruction. The plain abdominal X-ray shows how far the obstruction exists along the intestine. Minimal length of bowel needed to sustain full enteral nutrition, doubles in absence of ileocecal valve. Treatment: surgical. We have 3 goals: restore the continuity of bowel, preserving as much intestinal length as possible, and finally retaining the ileocecal valve if possible. And this concludes our part for the pediatric surgery for today.